Yes, nice. Good afternoon, everybody. I'd like to thank you for the invite to talk about the CBT and the behavioral therapy. That is a kind of treatment developed by a neurologist called Marsha Linehan. Talk about this, and then we will have some minutes to discuss the subject. I'm living in Brazil, South Brazil, here in Porto Alegre. That are talking the kind of treatment that see the treatment to use nowadays to treat personality disorder. Personality disorder is a really important disorder of borderline of personality disorder. When we can see an increase of the interest of this disorder in the 90s, because at this point we have no treatment effective to treat this kind of disorders, and this is due to the high prevalence rates of this. Is the prevalent personality disorder in the clinical practice, low rates of treatment success that we have until the 90s. Borderline disorder is when we have a pattern of instability in relationships and affects. So the only people thing in borderline personality disorder is the instability. We can find in this disorder a self-image disturbance that really of this disorder to have difficulty to be accepted environment in the childhood. And so because this, we will discuss more about this later. This will be a great factor to this instability in the present. Point important is the streams of idealization, evaluation to avoid abandonment, impulsivity, acts of suicide and self-mutilation, a feeling of emptiness, paranoid ideation, and we have also inappropriate anger. This kind of criteria is this criteria, the last one, that we have some doubts about this, because borderline personality disorder has a great instability of emotion, just anger. Probably the committee of the in the DSM-5 and also the DSM-4 keeps criteria in the diagnosis, because anger is the more related to external behavior. And so because this is here to find this kind of emotion more highlighted in the borderline personality disorder. But really we have the regulations of all emotions, including sadness, or we can see also loneliness, anxiety. So emotions when you have this kind of regulation. The regulation is linear that is the creator of the dialectical behavioral therapy. Shows that the emotional deregulation is the regulation that we can see in borderline personality disorder. And this kind of deregulation is related to the cognitive, interpersonal, and behavioral deregulation also. Dialectical behavioral therapy was a kind of treatment developed by Marsha Linehan, as I told you. She is a psychologist. She lives in the United States, in Seattle, Newark, and University of Washington. And the behavioral therapy is considered the only psychotherapy approach probably effective for borderline personality disorder, according to Task Force 12 APA. So this treatment is a mix of all kinds of the that Linehan had contact in the past, and create a theory that is based on all these reads that she had during all their career. So although sharing elements system with psychodynamic, client-centered, Gestalt, and practical strategies, it's the application of the behavioral science, mindfulness, and Eastern philosophy that defines the main characteristics of DBT. So, of dialectical behavioral therapy, including three main legs. When we have the first one is the interdependence ontology. This interdependence is related to all my behaviors to the environment, and this affects my behavior also. So it's really important to teach borderline personality disorder how to, because they frequently has a view of themselves. They are victims of the environment, victims of the another people that is related to the way that they interact with the another people. And so interdependence has an important concept to teach this patient to understand we are within ourselves, we lead whole, but it is related to the totality, but we have some practice that is related to the environment. And so the situation is important to teach personality disorder because I lack this concept in personality. And another leg, we see the polarity. Polarity, like yes or no, bad or night or day. So it's important to teach blind personality disorders to is a gray area between black and white. So the dichotomous thinking that are a kind of cognitive characteristic of borderline personality disorder. So it's important to understand that disorder has an important difficulties to understand the extremes because if I study and some hurt me, and so to hate these people. So this area is important to teach, and we can see in the strategies a lot of techniques that is possible to teach this. The way that science produces the concepts, thesis, antithesis, and synthesis. See, a thesis is an idea that can be a theory. We can have another idea that we can call antithesis. Another idea can contest the first idea. So when we have a thesis and we have another theory that contests that thesis, we can have another theory. And this new theory, we call a synthesis of the first and second. And the third theory could become another thesis that would endure for weeks and sometimes for centuries. So it's important to show the patient that we have not a standard and only truth. Ideas that can change along the time. These ideas that can change along the time help patient to understand that if I hate somebody, it's not necessary that this will be hated for forever. Change these emotions during and the childhood of the patient really difficult experience. This experience leads attribute to an invalidating environment. This invalidating environment is related to the etiology of this disorder. So, biosocial theory, theory that Linian understand that is the main the characteristic of the borderline personality disorder is the emotional deregulation. So, borderline personality disorder is mainly a system of dysfunctional emotion regulation that roots for logical irregularities combined with environmental dysfunction, their interaction throughout time. The borderline personality disorder are sequels of the regulation. The regulation in these patterns cause more deregulation. So the deregulation, interpersonal deregulation, cognitive deregulation, and behavior deregulation is attributed to this emotional deregulation that borderline personality disorder has. So, example of this dating environment, a patient, she is in her now. She from severe bullying in the adolescence and the childhood. In one of these periods, classmates schemed to not speak to her for 6 months. So nobody talked with her at the school. She did share this suffering with her mom. That she had probably done something bad to classmates. So the children in the invalidating environment don't have her emotional needs validated. So I am suffering for a violence, and I'm trying to handle with this situation. It's difficult for me to do this situation. And I asked for help for my mom, for example, and she and tell me you are wrong to do this way. In this case, was a really Catholic person. Brazil, Catholic country. 70% of Brazilian population is Catholic. Her mom told that, like Jesus, she needs to turn the other cheek and show compassion to those who were her. So her mom convinced her or her to do a party, a birthday party. Everybody to this party. This class that are hurting was really this situation, and her mom forced her to invite the classmates. And so her mom forced her to invite everybody to the party. She was obligated to invite everyone to the party. Emotionally, she was very hurt in that point, but she did the party. The party was on a Saturday. I went in this party and eat and dance and in this party. And on next Monday, I talked with her again. The situation that we can see in the borderline personality disorder is an invalidating environment that is a kind of environment when patient, the child receives the information that you're wrong for feel this way. You feel this way because you are unacceptable. So, the validating environment don't teach to act in different way. Just push children to be in this way. And so when you are talking about dialectical behavioral therapy, that there are assumptions of dialectical behavioral therapy. That is that patients are doing the best that they can. Is important to understand because when we are talking about borderline personality disorder, frequently these patients receive the level you are manipulative are not a person. You want to feel this way. Borderline personality disorder frequently is or angry or difficult to handle. So we understand that body don't have the skills to interact with another person in an assertive way. So we need to teach these skills to this patient. So behavioral therapy has a great social training in the component. The behavioral training of these patients with the skills that they don't have. Therapist does not need to wait for the patient to show the skills, but to teach the patient how to behave differently. Another important assumption is patients want to get better. So patients want to improve their skills. Patients try harder to be more motivated to change, and it's part of the treatment to motivate this patient to improve their skills and keep in the assumption important. This patient did not solve all the problems. They have to solve them anyway. So in dialectical behavior therapy, is like adults. So to treat person with Rett is patient as adults. So we need to responsibilize this patient to their behavior. So it's important to understand that borderline personality disorder is not victim of this dating environment, but are responsible to these difficulties they have. So suicidal borderline lives are as intolerable as they claim. New behaviors in all relevant contexts. So it's important to teach these people how to interact with the family, for example. We will not change the family. We will change the patient to interact with this family. So the focus of the treatment is in the patient, in the difficulty, and teach this patient to be responsible for this change. Patients cannot fail in the therapy, and treating borderline personality disorder needs support. Support could be supervision, clinical supervision, personal therapy. At times, is desirable. We have group of discussion of the person who will interact with this case, and will explain more this later. The skills of the therapist, in the treating borderline personality disorder include orientation for change and orientation to accept. So it's important to accept who I am and try to change who I am. So this is the dialectical view of the world in dialectical behavioral therapy. You need to understand that I need to have my emotional needs validated, but I change. So this balance is really important in the treatment. Orientation for change and orientation to accept. It's a benevolent requirement and stimuli to change and to keep in treatment. And is really important the fear conviction and also the flexibility empathic to that I need to be times and or firm with this patient, but it's important to understand that I need to be empathic also. So this treatment, the general overview of the treatment includes 4 main stages and 1 stage pre-treatment. The pre-treatment stage, we need to have the patient the commitment with the treatment and the goal of this treatment. So important, we have some important rules that will be discussed in the beginning of the treatment. This patient will follow these rules during the treatment. These rules could be discussed, and these rules frequently will change during the treatment. But important to discuss with this patient the rules that they need to do to start the treatment in behavioral therapy. And so this treatment is related to they miss a lot of sessions, they came to the session drunk or under effect of the substance abuse, came to the treatment and leave the session.
No, I had you guys on mute because I'm watching, but I figured there was the same problem that you guys are having. So I'm sitting here at my desk, but not through the computer.
The therapy.
Said to call the phone, you know.
Of the treatment, all these behaviors that affect directly the therapy will be discussed at the beginning of the treatment. And when we have this commitment about the treatment, we can start the first stage that aims to get stability, safety, and relationship.
Hear it from my computer.
So we are completely committed with this goal, and then we can start
file, edit, view
the first stage that could stay frequently 1 year, 1 year and a half, sometimes time depends on the severity of this disorder.
Teleconference.
When the stability in the
integrated voice conference, you want to make sure that you use
the way of this emotional works in this patient, can start in the second stage. Second stage, Linehan says that the patient has an emotional sensitivity that's like a burn on the skin. So this is a word that we use. The patient with borderline personality disorder has is a really sensitive of the emotional needs and the emotional. All we are with the skin burning, all is painful. So personality disorder is like a patient that is has an emotional all movement in the emotion is really painful for this patient. So this we will just explore the emotional processing of the past, frequently related to a lot of traumatic experience.
Voice conference.
When we can get the stability in the emotion. So it's important to understand that these stages have important structure to understand and to help better these patients. So third stage is problem solving and self-respect. And so here in this patient has a psychotherapy like all other patients without personality disorder. So we can have here problems that's the real life problems, like we will help the patient to reach achievement. We can help this patient to improve their skills, but here we have a patient stable emotionally. And we have the stage that is
and And then on
when
my own
we
computer, I
can,
went to the
at
mic to
the
make sure
end
that
of this
that was
treatment,
on
we
and
can
open.
have a sense of completeness.
That's on.
Here is
I'm
stable patient, not necessarily linear. Tell us that it's not necessary to read these skills in the therapy. Some patients have these skills working as a
Somebody got it. I hear it.
religion or in meditation settings, practice of mindfulness and another kind of meditation. So it's not necessary in some many patients don't reach this stage. It's not really necessary. So it's the cherry on top to finish. It's not necessary, but it's desirable. This treatment, this stage treatment. So the treatment. So the general objective is to improve the dialectical behavior patterns. We're talking about the behavioral. We have two different ways to interact with these patients. These including we have a reciprocal interaction. Interaction is validate the emotional needs of this patient. I will give some examples later about this. And we also the irreverent stylistic way of interact with the patient that is tell what the patient don't expect to hear from the therapist. So the reciprocal interaction aims to be stable, soft with this patient, and this corresponds to the 9% of the interaction with this patient. Different interaction that relates to a firm approach. Sometimes it's necessary to apply more pressure. It's like when we are walking on a tightrope, like the picture. We have some most of the movements on a tightrope soft. But to recover the balance, it's necessary to apply more pressure. It's necessary to change the speed of the interaction. And so we have these different ways to interact with patient to get the attention of the patient. When we are perceive that they are being manipulated by the patient, important to change this change the way I am interacting with this patient to get attention and then open the window to make the change in the therapy. So we will talk more about this later when I show you the dialectical strategies. Reciprocal and stylistic, as Lilian called, is related to validation. Validation of the emotional needs of the patient. This corresponds to 90%. Is telling the patient what they do not expect to hear from the therapist. So the therapist interacts with patients. You can have in one patient, for example, the session for not agreeing to a combination, for example. Call saying that she was at the bus stop and from a bridge. The receiver action, the therapist could say, I can see that is unbearable for you. You really take care of yourself. Therapy is more difficult at this point in your life. For you right now, maybe the police or a car to get you. Shoot with you about to taking a break in the therapy. So I'm trying to understand the patient and the emotional needs of this patient and try to validate these emotional needs. When the therapist perceives that he is being manipulated by the patient, he changes the interaction. So an example of the irreverent interaction is in the session, patient abandons the session and call to the therapist who will jump from a bridge. He could say, I know the hospitals to treat fractures. So patient don't hear this from the therapist, but if this to the therapist, we can open off the patient with all the therapist. Point, therapist can surprise the patient with a solution that the patient does not expect from the system, and we can validate the emotional needs after this interaction. So these 50, these two interact with the patient, the list will lose the power. So because it's important to use just some of this interaction, because it's not a the patient can't expect the way of interaction from the therapist. So dialectical strategies, the main dialectical interaction is the penetrate, the paradox, of metaphors, deviate, expand, enable wise mind, lemonade from lemons, allow natural change, and evaluation dialectic. I will some of them because that's an overview about the theory, so we don't have to go in these skills. But the use of the presents the history to try to make this patient to understand something. And so the therapist presents the paradox without explaining and highlight the paradoxical contradictions, and be true and not true, can be yes or no. So some example of paradox: patients are not responsible for being they are, but they are responsible for what they have become. To choose their own behavior, but to remain therapist if they do not strive to change it. They thought to achieve great independence, becoming more skillful to asking others for help. Have a reason to kill themselves, but if the therapist is convinced that the suicide is imminent, then it can be admitted. If the we travel on the weekend, for example, patient is in the middle of the crisis. Say to this patient, yes, it would be for you if not travel on the weekend, but this is a good opportunity for you as well. It's important that the patient understand that this will like view of the world to be more present in the functional daily life. The metaphor use something that the patient understands to help you understand by analogy something you do not understand. The stories are generally more interesting and easier to remember than speech or instructions. A lot of metaphors that can be used in the therapy. When we have a behavior that affects the therapy, we can use the metaphor of a client who refuses to use the material that is stuck, cook, puts salt in a cupcake of another cook, avoidance behavior and emotion, a burning building, stand in the rain amid the sun. When we have a suicidal behavior, we can tell the patient that jump off a mountain strapped to a structure. The structure therapist in this case, learn to accept. So it's a really metaphor. Tulip trying to be a rose because it was planted in a bed with rose. So to understand, without identifying with another people that is in my school patient that I told you, probably because I'm different from them, but not because of did something wrong necessarily. We can make a metaphor with a swimmer, a coach on the boat. So if the coach swimmer from the river, the swimmer will not learn how to swim. So it's important to face this situation to increase the skills and improve the skills to face the difficulties. Advocate use evaluation based on the patient's beliefs, resolve argument that is contrary to original beliefs. So, in the first session, to evoke a strong commitment to change the patient. The seriousness of this situation by the patient. So it is the emotional version of the devil advocate. This has the effect of making the patient see which consequences are exaggerated. Should be stressed to reduce the emotional consequence to the problem. It's particularly effective when it feels manipulated by the patient. So, patient to the therapist. If this therapy will not help me, so we that the therapist could reply this sentence: "It is not helping. We need to do something about this. We should change the therapist. Therapist should look for another therapist for you. This is really serious." So it's a situation that the therapist is validating this sentence, but the therapist is making more important. We will change the therapist, we will stop the therapy, and to this kind of with the patient, to do this kind of it's really important that we have a great attachment with this patient. If we have a great attachment with the main resource that the therapist can do is the attention. To use this kind of blackmail in the therapy, I need to have a great and strong attachment with this patient. So I can tell that the therapist must have leverage or in the bank to spend this. So we need to construct this attachment during the treatment to use this to help patients to change their behavior. Strategy: the made from lemons. Problems are seen as opportunities for the therapist to help the patient, are transformed into opportunities to practice skills. Use the question, what is being excluded here? So helping patient to not understand way that I interpret the situation, but trying in a different way this situation. It's important to keep the balance in the treatment, validation of the emotional needs and problem solving. Fundamental dialectic within any psychotherapy between the acceptance of what is and efforts to change what it is. So when we are treating borderline personality disorder, that the therapist is available for this patient. This disponibility is related to use of the phone calls, for example. So three different ways to call in the dialectical behavioral therapy is called at critical moments of crisis as a way to get support or to restore the therapeutic relationship. And the therapist, this kind of calls is from the patient to the therapist. And call to the therapist to help to get some help to handle with a difficult situation in their life during a crisis. We have kind of calls that is planned to occur between one session and another for whom. So if the patient has a consultation on Monday, he can have homework to call to therapist on Thursday, for example, to get a time between session and another one. So this contact with the therapist could discuss the difficulties that happen in that period, and it's important to understand that it could be an important extra support for the therapy. The last one is calling the therapist to the patient. So therapist call to patient. It's important to help patients to understand that with behavioral therapy, the good assertive behaviors. So call to the patient reinforces not the crisis behavior, but the behavior that the patient is not a call from the therapist to during a crisis. Is I know how he is doing, how she is doing, and to recover this attachment that must be strong. One of the important symptoms of the borderline personality disorder is the suicidal behaviors. When patients should call before a suicidal behavior, calls should not last more than 10 to 20 minutes. If the therapist this time limit has been exceeded, it's advisable to start a new consultation or call in the next day. And so to handle with this situation, we have a technique from dialectical behavioral therapy. It is the 24 hours rule. That rule when the patient in the beginning of the treatment, in the pre-treatment stage, we make an arrangement that patient can call to the therapist do parasuicidal behavior. It is patient to treat the impulsivity. That is a great characteristic of the borderline personality disorder. So if the patient cut themselves, the skin, or if they took all available or behavior that affect directly the therapy, prohibit from the patient to call to the therapist. So just give the orientation to look for an emergency service, and 24 hours later, you can call me back. So force to the patient is the attention from the therapist. And so we can use this attention to reduce the assertive behaviors and not the maladaptive behaviors. We can a lot of people with this patient. So we have in the in the therapy, we can have the therapist, patient, but we have also a social skills trainer, that professional that can is subordinated to the therapist. The therapist is the psychotherapist, individual therapist, but we can have time during the week, when extra time, when other professional will just train the skills and the skills that this patient don't have. This social skills trainer and the therapist could be linked to a DBT team. That's another professional, another people that knows about the case of this patient, and that can suggest that discuss weekly. So 1 hour, 1 hour and a half with this team to discuss and help this patient to keep directly in the treatment. So the patient could have a supervisor and she could have a personal therapist also. The social skills trainer could be a supervisor, could have a personal therapist also, and could have a psychopharmacologist, can have a physician, can have an inter team, therapeutic nutritionist, etc., and another profession. So a lot of people can be working with the patient, but the professionals that included in that meeting, and the another profession, Linehan call, there is another profession that works with the patient, but is not related to the behavior treatment. Understand that it's not easy to this to life, to our reality. So treatment out research context is not simple plug and play. So research world that is we have money to treat this patient. Patient have a lot of professionals available, a supervisor. We have a group to discuss this case. Patients have money to came to the treatment, to pay treatment, and life as it is. That is patient that can't go to the treatment, can't do everything that we need. So this is important. We are have in mind if we are adopting or adapting treatment to our reality. So cases to be considered is modification may or not or may not work as well as the original model. In case of research, offering a different model tested can bring complications to the ethical aspects. So important when we are talking about this situation in universities, and you has some university some tips to handle with this dilemma. So the tip 1, assess dialectical tension and look for the synthesis. Clear is to adopt or adapt the model with a small and tightly focused pilot program. Typical issues, functional issues, and principles of adherence, and one, use all available scientific literature to increase your success. The behavior therapy, that is a good description of the treatment, that a therapist is to teach, train, person, and lead her gentle to a way of being and acting in this world. This part, a cartoon that I find in the internet, but is related to dialectical behavior therapy. My goal in the therapy is to try to not think strictly in terms of black or white, good or bad. So far, I've spent the spectrum of white and charcoal gray. So gray area is really important to this patient to understand how to interpret the situation in a different way.
Thank you, Melo. So we have a few minutes left for questions. So if anyone listening has questions that you'd like to ask, please type them into the chat box or the Q&A box.
In the chat?
Q&A box. To remind you that we'll be recording. We've been recording the webinar and we'll be posting it on our website at www.paloaltou.edu. You can just search for PALO, and there if you want to watch it or share it with friends or colleagues. Thank you. No questions, but thank you. So thank you very much to Dr. Melo, all the way from Brazil, presenting this wonderful webinar for us today.
Oh, and I'm sorry for my accent.
I apologize. No. We have a question. Let's see. Q&A. Oh. Well, if you don't have any questions, let's see. Thank you all for your wonderful feedback. I'm glad you enjoyed this great and informative webinar with Dr. Melo. We will have another webinar. We're doing our webinar series monthly. Last month we did one on becoming a mental health counselor and the process that looks like. This month was DBT. Next month, our Dean and former Director of the PGSP Stanford University Consortium, PsyD Consortium program, will be presenting on how to prepare your application for doctoral programs in psychology. So website, we'll have that set up. It'll be, I think, the second or third week in October. Just as application season is coming up. So if you or others that you know are interested in applying to PhD programs in psychology or the social sciences, I'm sure they'll be of interest to you as well. We also we have more, like I said, scheduled for the next few months. One of Dr. Melo's friends, Dr. Robert Friedberg, one of our professors at PAU, will also be presenting, I think, in December on behavioral therapy with children with anxiety. He'll also, I think, be addressing some of the healthcare issue that's affecting at least us in the U.S. right now. Let's see. We'll have the webinar posted on our website. We have a question about the PowerPoint. Dr. Melo, will we be able to post your PowerPoint for the students to download?
Yes, of course.
Great. Okay. Yes, we will post those as well. Questions? If you have anything, please go ahead and type them in as we have just 2 minutes left. But again, thank you so much. Check back, like I said, to our website at www.paloaltou.edu. We page for our webinars, so you can see what's in the months to come. We also have on-campus, for those of you who are local, we have a lot of on-campus workshops and lectures and things often at lunchtime at our main campus in Palo Alto that are open to the public as well. Not being able to access audio, yes, we will post the recording on our website. So www.paloaltou.edu. We will post it. Thank you guys again for your wonderful comments and for joining us and listening today. If you have any questions and would like to email me, I'm at dberger@paloaltou.edu. And thank you again very much for coming. Thank you, Dr. Melo.
Very much.